Hi, everybody. My name is Adam Pick, and I'd like to welcome you to the webinar titled Advances in Aortic Valve Reconstruction. If I have yet to meet you, I'm the patient, the aortic valve patient, who started HeartValveSurgery.com nearly 20 years ago in 2006. The mission of our website is very simple. We want to educate and empower patients just like you. And this webinar, which has had over 400 registrations from patients in countries all over the world, was designed to support that mission. Now, throughout the webinar, you're going to be in listen-only mode, but I'd encourage you to submit your questions in the control panel on your screen. And as we look at the agenda, it'll become clear why I'm going to ask you to do that. To start, I'm going to introduce our featured speaker. We're then going to look at the aortic valve. We're going to get some true and really clear understandings about what aortic valve reconstruction techniques are. We're going to look at the outcomes. Then we're going to get right into that Q&A session. Lastly, I'm going to ask you to complete a very quick 5-question survey. Now, as for our featured speaker today, I am humbled and I'm honored that he's taking time away from his very busy practice. And who is he? Well, Dr. Lars Svensson is the chairman of the Heart, Vascular, and Thoracic Institute at the Cleveland Clinic in Cleveland, Ohio. And let's look at his specialties, which are aortic valve surgery, aortic valve and bicuspid valve repair, complex aorta surgery, Marfan syndrome, modified David's reimplantation procedure, transcatheter approaches, and minimally invasive techniques. Now, it's one thing to have all these specialties, but to put them into practice is something different. And so let me just share this with you. Dr. Svensson hasn't performed just 100 cases or 1,000 or 3,000 or 5,000. He's performed over 10,000 cardiac surgeries, of which 4,000 have included some type of valve operation. And it's not just the incredible volume and the lives that he has changed over the years, but he is also very deep into the innovation and the research that may have already impacted the people on this call or those who will need some type of operation in the future. When it comes to his impact on our community, I do want to share this with you. I looked in our database and I looked at some of the patients that he's helped over the years, and here they are, whether it's Sean Adkins or Daniel Conrad or Alan Neff. These are all patients from the HeartValveSurgery.com community that have gone to Dr. Svensson and are living great lives, as evident by some of the smiling faces that you see here. He's helped, for example, Robert on the left with an aortic valve repair. He's also helped professional athletes get back to playing the sports that they love. And so I'm going to welcome Dr. Svensson, but I also want to share with you a personal note. Dr. Svensson was one of the first physicians who agreed to film a video with me at a conference. And at the time, I don't know if you remember this, Dr. Svensson, I only had a flip camera, and everybody looks right there. You'll notice the year, it's 2011. So Dr. Svensson, you and I have been going at this now for over 14 years. And from the bottom of my heart, I can't thank you enough for being here with us today, helping all the patients that you have in the past, in the present, and in the future. And with that, thanks for being with us, Dr. Svensson, and I'll turn it over to you and I'll give you the controls.
Super. Well, thank you so much. It's really my pleasure and privilege and honor to talk to you. I've had a long interest in this, as you mentioned, Marfan syndrome, because one of my friends had it. And this has been a long journey, and you've been very much part of it, Adam. So I appreciate the opportunity to talk to you and everybody who's on this website, and been very grateful for the many patients over the years who've entrusted their care, both with myself and my colleagues here at the clinic. And so it's a privilege to chat to you. I still operate every day and do 1 or 2 cases every day. And a lot of what I do is aortic valve repairs. And so that's why we're going to concentrate on that, both isolated bicuspid valve repairs, 3-leaflet valve repairs, and talk about the connective tissue disorders. So just to set the scene, last year we did some 3,970 valve operations here at main campus at the Cleveland Clinic, and about 770 of those were root operations, and we did over 200 reimplantation operations last year. And my personal series is over 600 reimplantation operations. And we'll talk a bit about the outcomes of that a bit later. So the aortic valve, obviously, as you know, is at the top of the heart, with the coronary arteries coming off the sides of the aorta just above that. And the reimplantation operation, therefore, involves freeing up the aortic valve and putting a graft around it and reimplanting the valve within that tube and then hooking up the coronary arteries. There were also the remodeling operations that we don't do as much of now because we've noted that the reimplantation operation is a better operation when it's required for patients with root dilatation. So here are some things to keep in mind that we think of as surgeons as far as whether a repair is possible or not, and that's all repairs, not just reimplantations. How bad are the leaflets torn, and is it dilatation that's causing the leaking valve? Calcification usually means we're not able to do a repair, but we do sometimes do that with bicuspid valves. The usual presenting symptoms are fatigue, dizziness, occasionally chest pain, but leaking valves typically take longer to present with symptoms as opposed to the narrowed down valves, aortic valve stenosis. And if it's not treated, regurgitant valves, leaking valves cause heart failure. Not as often sudden death, but that happens more with the stenotic valves, and that's about 1% per year. At this time, there's no medication that cures progression of aortic valve stenosis. We certainly can see some medications like lisinopril slowing down heart failure with regurgitation. And then as far as incisions and operations, the majority of my bicuspid valve repairs or ascending plus bicuspid valves or 3-leaflet valves plus ascending aortas, I do with a minimally invasive J incision that I described many years ago, and it was the standard operation for Toby Cosgrove that he adopted for mitral valve repairs too, and I still use that for mitral valve repairs when a robotic approach is not feasible. And we'll talk about valves and aneurysms, but basically when it comes to stenotic valves, the options that you have to consider with your surgeons are replacement with a biological valve versus mechanical valve. And in patients without aneurysms, the Ross procedure, and then one of our surgeons does a lot of these so-called Ozaki procedures. So this is the kind of valve that unfortunately we cannot preserve because of those perforations in the leaflets. And here's a calcific valve. So this is the aorta side of a bicuspid valve, and this is what it looks like on the undersurface, and that's why we have to replace those. So 771 root replacements in 2024, 467 of those were the so-called Bentols, 64 were homografts, so human transplant valves, and 210 valve sparing operations with reimplantations, and then 30 Ross procedures. So let's just talk about root operations and outcomes. This is a study from a number of years ago that I looked at 957 patients, and this was mainly elective surgical patients with either the remodeling operation, which would be this operation where we cut a slit into the graft and sew that to the annulus. Then the reimplantation operation where the valve is freed up and put inside a graft. And you mentioned Jeff Green just moments ago. He's been open and they have done a number of interviews. This actually is his valve after reimplantation. So I've had 6 NBA players as patients for these kind of issues. The biological composite valve grafts, we put a biological valve into a tube. Joe Bavaria and I were involved in working with Edwards and designing what's now called the Connect valve, which is a composite valve graft, and the results look pretty good on that. And then you have the other composite valve graft techniques. This is a technique I described many years ago for complex repairs with a tube graft to the left main, with a mechanical valve and homografts. And in this study, the numbers were about equally divided. And from a survival point of view, Bentol's and valves preserving operations had the best, but remember, these are younger patients. Bentol's were biologic, which are typically older patients, didn't have as good a survival. So what about timing of surgery? And this is based on a study I did when I was in Boston with Marfan patients. And we found that when the cross-sectional area of the aortic root divided by the height of the patient is more than 10, that is an indication for surgery. So in a shorter person, that might be at 4.7 centimeters, and for a taller person, 5 centimeters. And one of our cardiologists, together with some residents, then looked at this using CT and cross-sectional area. And when that ratio is less than 10, the long-term survival is not good. And it's particularly so for patients with root aneurysms as opposed to the ascending aorta. So this is now in the guidelines as one of the measures used to deciding when to operate. This is another study looking also at size and the risk, and the inflection point is somewhere about 4.7 centimeters in this case for the increasing risk of dissectional problems. So we looked at at patients with bicuspid valves and the aorta more than 4.7 centimeters over time. We had 1,000 patients, 801 had surgery. In those patients who had the combination of valve and ascending aorta, the risk of death was 0.25%. And in the surveillance patients, we followed a number of those patients over 10 years. And the inflection point for dissection was at about 5.2 centimeters. And obviously, you want to operate before dissection happens. And so that's why we recommend 5 centimeters or that size ratio of 10. And when we looked at this more specifically, or all the indications, or parameters to use for timing of surgery, the cross-sectional area to height is the best one. Over time, people started off at 4.7 centimeters, 50% needed surgery within 10 years, and the larger the size, the more risk of needing surgery. These are the things I look at, a schema I use to decide how to repair a valve and what's needed. You look at the commissures, the leaflets, the annulus, the sinuses, and the sinotubular junction, and all of those need to work together for a successful and long-term durable repair. I'll just mention a bit about the classification of bicuspid valves. This is something that we worked on, and essentially we looked at, is this just a minimal bicuspid valve, a narrowing at one of the commissures? Then we look at symmetry, not that important from the point of view repair, and then the orientation. Most patients have the fusion of the left and right leaflets, less so the right and non-coronary, and pretty rare is the fusion between the left and the non-coronary. And then annular diameter gives us a lot of information about how likely we are going to be able to repair a bicuspid valve. The RAFE, we look at that too, and as I mentioned, if there's a lot of calcification there, that usually is an indication that the valve repair is probably not going to hold up long term. The basic steps for a simple bicuspid valve repair that is regurgitant is divide the raphe that frees up the conjoint leaflet, and Cabral sutures at the commissures to narrow the intercommissural angle, close any incomplete fusions, and then something that I started using, goodness, it's about 20 years ago, is a figure 8 stitch at the commissures to hitch up the leaflets. And here
And
you have
Dr. Svensson, can I ask you real quick? We might have some
Sure.
patients who they may have been diagnosed yesterday
Yeah.
with some form of aortic valve disease, and there's some language here they might not know. And I don't want to turn this into just a vocabulary session, but can you quickly, what you're describing in terms of how you go through the criteria for the possibility of a repair is fascinating. And if you could describe maybe just those, maybe the RAFE and the commissures, what those are as you're going through this, the planning process.
Sure. So the raphe usually is over here where there's a fusion. Here you have an incomplete fusion of the leaflets, and then the commissures are over here, and the intercommissural angle is this angle here. And so the Cabral sutures bring that together to narrow that angle, which improves the apposition of the leaflets. And then the figure of 8 sutures does that also, but it also hitches the commissure higher up. So here I tried to show that. It brings it up so you have more apposition of the leaflets, which improves the ability to control the regurgitation of the valve. I'll show some of the anatomical features as we go through here. Here's another figure of 8 suture on a bicuspid valve. So what about bicuspid valve repairs? Between 1985 and 2011, we'd done about 2,000 bicuspid valve repairs, and we looked at the more recent population up to the end of 2011. We're about to do another study of this, but in the more recent operation patients with more better techniques, the durability was better. Now, obviously, we don't have 15-year follow-up for all of those patients, so just make that point. What about the contemporary repair techniques? A lot of different operations and techniques, but I mentioned the Cabral and the figure of 8 technique. And the freedom from reoperation at that series was 91% at 10 years. So these are patients who otherwise would have had their valves replaced, either biologically, a biological valve or mechanical valve. And we've got data to show that if patients have a successful repair, they are much better off than having a biological valve replacement over time.
And Dr. Svensson, just to add in a really quick question for you, we've learned that sometimes when patients choose a tissue valve, one of the factors for them might be because they don't want to go into blood thinners like Coumadin. Are there ever situations when you do some kind of reconstruction technique and the patient also needs to go on some form of blood thinners? Or when you say freedom from reoperation, they have no medication, they have just living a normal life without any medication?
That's correct. So the only thing I recommend is they take a baby aspirin a day. I think that's always wise in this population, but they don't need to be on blood thinners. The only reason for a blood thinner would be if they've got atrial fibrillation or some other reason, and then one of the newer types of medications that don't need blood testing, like INR, is the usual way that that's treated.
Great, thank you.
So the figure of 8 stitch seems to result in better results long-term in patients that we use it. And also when we do a root repair with bracing of the root, just from a technical point of view, that seems to result in a better repair over time. One question that people ask, how's my long-term survival? So we matched survival with age and sex and race for the United States population. And once people get over the initial operation, the long-term survival is the same as the general population. And for example, this year we have had no deaths for any aortic valve replacement or aortic valve repair. isolated valves, that is, and we do about 400 a year. And so I often say to patients, I haven't had a death after an aortic valve replacement for the last 10 years. So the results here at the Cleveland Clinic are really good with the replacements and the repairs, and your life expectancy should match the rest of the United States. So from a recommendation point of view, when it comes to repairs and talking to your surgeon, I recommend they follow the schema I mentioned. Avoid repair in patients with aortic valve stenosis and fenestrations, and the figure 8 stitch really makes the repair more durable. So one of the questions we had for patients who came to see us was, should we be more aggressive in replacing the ascending aorta above the aortic valve to improve the durability of repairs? And so one of my trainees looked at that, looking at the outcomes over time. We had 842 patients that we matched for that comparison, 421 in patients who had repair plus ascending aorta plus repair alone. And when we matched outcomes, overall mortality in that series was 0.4%. And late outcomes basically showed, when it comes to survival, no difference in the significant survival over time out to 12 years, no difference in regurgitation from the valve, leaking valves over time, no difference in dilatation of the aortic root or the ascending aorta afterwards, and reoperation for aortic valve stenosis development was the same in that population, and no difference in reoperations for aortic valve regurgitation. So this one point is important because I thought maybe if we replace the ascending aorta, the repair freedom from reoperation would be even better. But on the other hand, here you have again that number of 91% freedom from reoperation at 10 years. So that's about the standard for these patients. And risk of root dilatation, as long as the root is replaced, if it's more than 4.5 centimeters, no difference in outcomes. So that's basically the keys from that study. But I think it's important that if the aortic root is more than 4.5 centimeters, it usually needs to be replaced. But a lot of things come into that decision making, including whether reimplantation is feasible or not. So let's talk now about the modifications for the reimplantation operation. The key ones are putting pledgets in the left ventricular outflow tract. So the aortic valve here has been freed up and pledgets have been put through the pumping chamber underneath the valve. And those are going to be put into the new tube graft, and then the valve gets reimplanted. The other thing that's key to this is using what we call a Haygar's dilator. So this is a measured size that we use to tie down those stitches I showed you. And that ensures that we don't over tighten these sutures and narrow the aortic valve excessively. It's the aortic valve annulus in particular. And also that we bring down the size to a normal size. So some patients, for example, with Marfan syndrome may have a 4 centimeter aortic valve annulus, and that also affects the long-term durability of these valves. So that's the reason why we use the Haygar's for reimplantation of the valve. And here's the valve just then sewn in position with the coronary artery buttons that are going to sew onto the sides of that root.
Dr. Svensson, can I ask you a real quick question?
Sure.
I don't know if you can see me. I'm shaking my head up and down and side to side in amazement by all of this. And getting back to the reimplantation, I'm curious to know, when I saw you describe how you use the pledgets for the annulus and keep maintaining the structure, it kind of reminded me of a mitral valve repair ring to some extent. But that's not what it is. And I'm curious, for the folks on the line, how did you come up with that innovation to use pledgets? Do you remember what caused you to think, hey, we can use pledgets here to help out the annulus?
Well, what I discovered in looking at what people were doing was that the sutures were pulling through. and people were ending up with so-called fistula, which means a communication between two chambers in the body. So there were holes being made in the mitral valve. There were ventricular septal defects being created, holes in the right ventricle, and causing leaks between the chambers of the hearts. And particularly in patients with Marfan syndrome and Loeys-Dietz, their tissues are much more fragile. And so the obvious, to me, thing was to put platelets on those so the stitches did not tear out. And that's a basic principle we use in a lot of aortic and valve surgery, is to use platelets. And so over time, platelets have become the way that most valve replacements are done now with both mitral valve and aortic valve. We use platelets for that. So that was the key from that point of view. And when it came to using the hay gauze, that was because I was seeing Marfan patients with these very big annuli, and part of the reason the valves were leaking was because the annulus was very big. And so I thought it was important from a durability point of view, long term, to bring down that size. And we'll talk some more about it, but that, I think, is one of the key reasons why the freedom from reoperation is 95% at 15 years with these modifications of the reimplantation operation, which means the results are just as good, getting back to your comment, as a mitral valve repair. So a good done reimplantation operation should have the same durability as a mitral valve repair for a posterior leaflet that has ruptured chording.
Great, thank you.
All right, so let's talk about the connective tissue disorders. As I mentioned, this has been a long interest of mine since a friend of mine had it. I played rugby with him, and if I can interject a personal note, I pushed on his butt, and so I always had a good relationship with him, and we were great friends. And then when I worked for Dr. Crawford in Houston and trained with him, he gave me the privilege of reviewing all his Marfan syndrome patients, the biggest series at that time of 151 patients. And in that group of patients were patients who clearly had a connective tissue disorder, but did not meet the Ghent criteria for Marfans. And in retrospect, those were patients with Loeys-Dietz. And so I called them Marfanoid in that series. And then obviously Ehlers-Danlos loss has been known for long term. So this is our 214 patients we studied a few years ago with connective tissue disorders. And in that series, there were no operative deaths for the 214, small risk of stroke in that group of patients. So what about risk of reoperation over time? In that series, the freedom from reoperation at 10 years was essentially exactly the same, slightly better with the patients with connective tissue disorders. So really great results. The fear we had when we started doing reimplantation operations for connective tissue disorders was that the leaflets were abnormal, they'd fail over time, but that has not been the case. And so we are actually very happy with the 4 patients and the long-term outcomes. Last year at AATS, you mentioned this, one of my trainees presented my personal series of 528 patients up until 2024 for reimplantation operation using the modified reimplantation operation. 38% of those patients had connective tissue disorder and various grades of regurgitation and ages. My oldest patient is 81 years old and still doing well when she had her reimplantation operation. Some of the intraoperative results, typically the clamp time is less than an hour. So that's the time that the heart needs to be stopped for the operation and do a valve reimplantation. If additional things need to be done, like coronary artery bypasses or mitral valve repairs, that adds to the length of the operation. And concomitant procedures, as I mentioned, the mitral valves, coronary bypass, and that outcomes series of mine, there were no deaths, and new pacemaker rate is 0.62. So if you compare that with patients who have ventral operations, in other words, have the valve replaced, that usually is about 2% to 3% and a low stroke risk in this series. Survival at 15 years is 87% of patients are alive. No difference with survival with connective tissue disorders. And look, this is one of the great successes in cardiac surgery. The life expectancy for patients with Marfan's used to be 32 years. Now patients are living well into their 70s, and I get notes from patients, and it's just one of the great successes in heart surgery. So for those of you who have the unfortunate connective tissue disorders, once you have the valve and the root fixed, the long-term prognosis really looks good. What about freedom from reoperation overall? In my series, 95% freedom from reoperation at 15 years, and connective tissue disorders, slightly better results than the non-connective, but that's probably influenced a bit by bicuspid valves in that series. So here's the bicuspid valves. No significant difference in outcomes with reimplantation in patients with either tricuspid or bicuspid valves. And this is a survival. Survival is excellent in both categories of patients. And the risk of regurgitation over time, moderate, is about 10% over time. But typically, moderate regurgitation does not need an intervention and doesn't need any further treatment. So the modified aortic root reimplantation is a reproducible operation. A lot of surgeons are doing it. If you look up on YouTube, there's one that I did on Lois Dietz. So if you look up Lois Dietz reimplantation under my name, you'll see some description of that. And the great thing is the outcomes. One other comment for those of you who are concerned about biological valves, there is a lot of controversy at the moment within the surgical community, and patients basically are given the option of choosing between mechanical and biological valves. Since 2010, the risk of having a reoperation aortic valve replacement at the Cleveland Clinic is no higher risk than the first operation. And that particularly is important when you think how you may need to manage a reoperation for a biological valve. And so this is a very safe operation here at the Cleveland Clinic. So with that, I'm open to questions and answers. And again, it's my privilege to chat to you. Delighted so many of my patients have come from your forum, and it's our pleasure to help you in any way we can. And I didn't put my phone number up there, but my office number is 216-445-4813. And my secretary, Rhonda, is fantastic at answering the phone. And Lindsay Hackney is my nurse practice manager, and she chaperones you through everything, presents your studies to me, I review them, and usually within a couple of days, I can get back to you on what my recommendations are. So thank you very much for the time and opportunity to speak to you.
Wow. Well, Dr. Svensson, we're going to get to the questions and answers. But first, I really, on behalf of our community of patients and patients all over the world, I can't thank you enough for not only just giving patients back almost near normal life expectancy, but also the quality of life that you have bestowed upon them and their families and their friends. It really is extraordinary. And I know that last 40 minutes of time is just a snippet and a peek into your life. But on behalf of all the patients, thank you for everything you're doing. And maybe we just start with that, which is this, you mentioned kind of your patients where they come from. I'm guessing all over the world. I know you talked about Jeff Green, the NBA player who has gone back to playing championship basketball. If somebody does want to learn more about this technique and contact you, do they have to come to the Cleveland Clinic? Can you do a remote consultation? How does that work?
So the limitations on doing virtual consultations is the problem of the regulations, that we cannot do that if I don't have a license in a particular state. So the way I usually do this is people phone my office or the cardiologists contact me, and then Rhonda, my secretary, gets all the studies together that are available at the time, and Lindsay then puts that together, and I sit down with Lindsay, reviews everything with her, and then she calls the patients and tells them what my recommendations would be and what testing may be needed. And if it's a clear case of needing surgery, she will review everything with me and then talk to the patient about when there are openings in my calendar, when it works for a patient's timing to come to the clinic. And typically, we'll get some breathing tests, an echo here, and cardiac catheterization is standard for most patients with these operations. And then we also offer some dates for surgery, typically within a day or two of coming to the Cleveland Clinic.
Yeah, and for the folks on the line, I know that your team has gone about making this as frictionless as possible and streamlining the entire process. So thank you for that. Now the patients have some direction. Let's get into the question and answers, and we've gotten a bunch of them, Dr. Svensson. This one comes from Krishna, who's actually one of your patients. And he says, Dr. Svensson did aortic root reconstruction surgery along with valve replacement and partial removal of the dilated aorta. It is now 14 years later, and I'm 80 years old. My injection fraction has come down to 55. My BMP is at 183. A brisk walk makes me feel a little bit short of breath. What would be recommended procedure when I need a reoperation, TAVR or SAVR?
All right, so that's a personal choice, but I would think most people who are 80 years of age would go for a TAVR, but certainly a replacement of the aortic valve is also feasible. A couple of weeks ago, I did, I think, 5 or 6 like that within a week period, where I went into a biological valve composite graft, took out the biological valve, and put in another new valve. So that certainly is feasible. It's safe, and it's worked out pretty well in my hands doing it that way. But that becomes a question of personal choice. I think if you're 80 and your valve is still working well, you may very well not need another operation, hopefully not, but those are 2 very reasonable operations. In our hands here at the Cleveland Clinic, only after the age of 85 for a reoperation does the risk of a reoperation start increasing. So that gives you a sort of baseline number.
Great. Thanks so much. And for the folks on the line, feel free to go ahead and use the control panel to ask your questions, because we've got some great time here to answer them live. We have another question that came in from Hugh, all about bicuspid aortic valves. And he says, I've always wondered why the conjoined flaps of a conjoined aortic valve just can't be separated to enable the natural tissue to be retained. Surely it's simpler than separating Siamese twins.
Well, I like the way you're thinking, but unfortunately, I don't want to get into a comparison to Siamese twins, but there's not enough leaflet tissue. And we went through a period where we tried to add tissue in the sense of either native pericardial valve tissue or calpericardium. And the problem was that there's a high risk of clot formation. And usually with clot formation, you get calcification apart from pericardium from cows, bovine pericardium, has a higher rate of calcification. And so we discovered that it's better to keep the leaflets bicuspid. There is typically with bicuspid valves excess tissue. So that means the annulus in a bicuspid valve is big than a 3-leafed valve typically. And so the bivalve is better accommodated in that situation than one would expect.
Great, Hugh. I hope that helped you. We're going to go real time to a question from Christine Geyser, and you've referenced this a bit, Dr. Svensson, about atrial fibrillation, an abnormal heartbeat. And she asks, what is the incidence of AFib after open heart surgery, whether a repair or a replacement?
Yeah, that's an interesting question. So essentially, virtually all patients who have heart surgery with a full sternotomy, the risk of atrial fibrillation is about 25 to 30%. It's higher with, for example, mitral valve surgery than aortic valve surgery, and there's some operations that carry a lower risk. We know the minimally invasive J incision tends to have a lower risk of atrial fibrillation after surgery, as does robotic operations. Now, having said that, we just completed a big study on over 1,000 patients where we looked at genetics, inflammatory markers, and the risk factors for atrial fibrillation after surgery. So the biggest correlate with the risk of atrial fibrillation is age. The one that was very interesting from a genetic point of view was that patients who are genetically predisposed to developing atrial fibrillation over their lifetimes had a higher risk of atrial fibrillation after heart surgery. In other words, heart surgery brought out that risk of atrial fibrillation at an earlier time. So we haven't solved that problem of atrial fibrillation after surgery. About 95% of patients within 2 months of heart surgery with atrial fibrillation, that is de novo, in other words, the first time, are back in a regular heart rhythm. So most of the time, it's not too much of an issue.
Great. Thanks so much. Christine, I hope that helped you. Here comes in from Andrew, all about aortic valve size. Can you talk about your evaluation of aortic diameter in the presence of bicuspid valve to determine risk level and need for intervention? Is there an algorithm for determining open heart or TAVR?
So as I mentioned, the patients with bicuspid valves tend to have a bigger annulus. And so from that point of view, typically the determination of open heart surgery versus TAVR is not a factor in patients with bicuspid valves. I saw a patient today that on transthoracic echo, they said the annulus is only 1.9. But I know from experience that that annulus is going to be bigger than that because it's a bicuspid valve. And so I probably won't need to do an annular enlargement. But back to the discussion about bicuspid valves and TAVR, we know the risk of stroke is higher. And so Dr. McCarr from Cedars-Sinai did that study. We also know that the risk of dissection in patients with enlarged aorta is higher. Bicuspid valves, usually in younger patients, which we don't recommend TAVR. There are now 3 peer-reviewed studies, including the New England Journal of Medicine, showing that after 3.5 years to 5 years, depending on the study, the risk of death and stroke have crossed. In other words, after about 5 years, the risk of death and stroke are higher with TAVR than they are with open surgery. Now, there's a statistical analysis that has to be done on that, and that really hasn't been done yet, which is restricted means analysis. So what I say to patients, well, how long do you plan to live? And that's going to be a factor in determining which you choose. When it comes to durability, so far, we don't have data to show a separation between the TAVRs and the open biological valve repairs. And we know from history that in the patients who have open biological valve replacements, we only start seeing that separation occurring at about 9 or 10 years. Now, we have, and I was the principal investigator for the Resilia valve, which became the Inspiris valve for Edwards. And in that study, we had some 689 patients. We've only had 2 failures with the dry storage leaflets for the Resilia valve, one at 5 years and one at about 7 years. And we've got a paper that we're working on now with the Inspiris valve, which is the FDA-approved version of the Resilia valve, also showing very good outcomes and better than the old gold standard, which was the Carpentier-Edwards pericardial valve. So we feel pretty reassured about the durability of the open valves. The other part of this that we don't know the consequences of is that, again, Dr. McCarr, 22% of patients with TAVRs have clot formation on the valves, whereas the open valves, it's about 7 or 8%. The long-term consequences of that we don't know yet, at least at this stage. We haven't seen a separation and durability, but we are seeing that separation and the risk of stroke and death.
Well, I thank you for bringing and shining the light on that research. I was not aware of that. Very great to hear that you're seeing some extra durability with the Resilia Inspiris tissue from Edwards. We have you kind of alluded to this in your conversation just now, but we have a question from Ann Fisk. This is going real time, Dr. Svensson, all about echocardiograms. And she asks, can an echocardiogram give a false positive for an aortic valve regurgitation?
Well, that's a debate that the cardiologists constantly have. And, what is the best thing to look for with regurgitation? And so I think I talk to my expert cardiologists about this on a regular basis. They give about a 10% error rate for regurgitation numbers, and they are derived numbers. The area where I see, particularly since we got into the stenosis problem, a underestimation of the severity of valve disease are the patients who have mixed disease. In other words, they have a combination of a narrowed valve, aortic valve stenosis, and a leaking valve, aortic valve regurgitation. And those patients tend to be underestimated on echo for their severity of disease. Again, I happen to see a patient today who has severe restriction on his breathing ability, but his breathing tests are excellent. His FEV1 is superb. And yet he is not coping, and there's a big question mark on how severe his aortic valve disease is. And based on my experience of the combination of aortic valve stenosis and leaking valve, he has severe disease, and I have no doubt that in 6 months he'll be feeling considerably better, if not within a few weeks after surgery.
Thank you. And now we're going to move over. Again, you touched on this too, but a question came in from Jenna all about genetics. She asked, is there any update on genetics specific to aortic valve disease and aneurysms that we should know about?
All right, so let's take aortic valve disease with stenosis. No genetic particular predictors there, but on the other hand, there's more evidence that lipoprotein A is a factor in developing stenosis and progression of stenosis and the rate of progression of stenosis. And so that's why there are now trials looking at medications to reduce lipoprotein A with the idea to slow down the development of aortic valve stenosis. In bicuspid valves, as common as they are, you'd expect to see more genetic findings associated with bicuspid valves, but that is not been the case. And so there's really just one gene that's been associated uncommonly with bicuspid valves. And so that is not strong. When it comes to aneurysms and root aneurysms, so about 50% of patients with root aneurysms have a genetic underlying inherited valve problem or genetic disease. And obviously Marfan's and Lowe's-Dietz are the ones. But we're seeing more and more now of genetic mutations that seem to be associated with root aneurysms. And so we're working on doing some papers on that. We have a free genetic test here at the Cleveland Clinic for people who wish to have it done. And we're beginning to see some other mutations showing up as potentially associated with aneurysms. So the list of mutations associated with aneurysms is growing. And we're beginning to understand also much more the subgroups, for example, with Lowe's-Dietz.
Got it. And this is a very interesting question from Helen, who says, I'm an operating room nurse. Is there a better, more efficient, safer, newer blood thinner than Coumadin after an aortic valve replacement?
Well, that's a very good question. And that was top of my mind a few years ago. And so we set up this trial with the mechanical onyx valve with the idea of, could we choose a population of patients who would be ideal for using one of the new non-Coumadin blood thinners? And in this case, we chose to use Eliquis. And so we randomized patients to either Coumadin or the non-Coumadin, one of the new medications. And unfortunately, we had to stop the trial early. Our safety committee found that we had a greater risk of stroke in the patients who did not have Coumadin. And so, and that was a trial where we started this 3 months after starting or having had the patients on Coumadin. So we set up the trial for ideal situation to make it work, and unfortunately it didn't. So I think the feeling of most of us, it does not look like at the moment with the current valves and the current medications, there's an option other than Coumadin for these valves, mechanical valves.
Great. Well, I hope that helps you, Helen. And on that note, we're coming to the end of the time that we had allotted for the webinar. And what I'd like to do is please don't sign off the webinar just yet. I want to thank you, Dr. Svensson, for, again, just all the commitment, dedication of you and your team being with us today and sharing your experiences and research with us. Thanks, Dr. Svensson, for being with us today.
Thank you. My pleasure. And we're always available to help. And thanks, Adam, for a wonderful job. It's a wonderful resource for our patients. And thank you for everybody who participates and shares the information with other patients.
Hi, everybody. It's Adam. I hope you enjoyed that video. And don't forget, you can always subscribe to our YouTube channel, watch the next 2 educational videos coming up on your screen, or click the blue button to visit HeartValveSurgery.com.